and I would say a third of the audience are people that I know or have given talks to in the past. This is a field, cardiopulmonary physiology, that I've been studying since about 1978. And I would bet that if I asked anyone here who wasn't born in 1978, more than half of you would be raising your hand. So I can say safely, before you were born, we knew this. So let me go through this field, this fascinating field of heart-lung interactions. It's a personal journey that started for me when I graduated from medical school in 1974 and I moved to Stanford. And I'd always been curious of why heart-lung interactions were never studied, never written about in textbooks, nor taught to medical students. They simply weren't. And the reason, it turned out, if you thought about it, was absolutely clear. The oldest specialty of medicine is pulmonary medicine, tuberculosis, empyema, pneumonia. And on the modern world, they were just developing in 1974 these things called intensive care units. And they had a medical intensive care unit for chronic obstructive lung disease, so their entire focus was on ventilation of COPD patients. On the other hand, cardiology took care of the heart, the pulmonary circulation, and the periphery, and they were by far and away the largest and most powerful specialty, with large quantities of money going to the cathing cardiologists. And thus you had these two giants who, because of that, when they talked about pulmonary hypertension, they either talked about right ventricular failure or pulmonary hypertension. They never talked the same. And nobody ever thought of it at all as a cardiopulmonary unit. But the reality was that nature doesn't care what specialties we've created. Cardiopulmonary units are a reality. COPD causes cor pulmonale. We have breathing-induced cardiovascular insufficiency. Asthma induces pulsus paradoxus, and if it gets too bad, you get pulmonary edema. Upper airway obstruction classically presents as pulmonary edema, and ARDS, as we knew for many years, was associated with profound left ventricular diastolic and systolic dysfunction. So, is intrathoracic pressure, that pressure within the chest, is that the key? Well, negative swings in intrathoracic pressure occur when you breathe. You contract your diaphragm, you pull on your ribs, and that makes the ribs swing up like a bucket wing thing, so that the chest wall, the chest's thorax has an increase in volume apparent. And this negative pressure that's created by this increase in volume pulls open the lungs, and this is the negative swing in intrathoracic pressure. We know that, and before I started, we knew that lung disease induced heart failure in patients who had no evidence of it before. And if you take in a breath against an occluded airway, which is called a Mueller maneuver, it could alleviate the outflow obstruction of asymmetric septal hypertrophy. That's the cardiac disease in which the outflow tract of the left ventricle is hypertrophied, and therefore when the heart contracts, it actually closes down like aortic stenosis. And if you give that sort of a person norepinephrine or phenylephrine, you can abolish the obstruction. By just increasing afterload on the left ventricle, it keeps that open. But a Mueller maneuver did the same thing. We knew that asthma caused pulmonary edema, and upper airway obstruction caused acute cardiogenic pulmonary edema. These were known. How did it all fit together? Well, when I was sitting in my fellow's chair at Stanford many years ago, a friend of mine, Andy Buddha, said, "Michael, you're a physiologist. I think what's happening is the negative swings and the pressure in the chest is impeding the left ventricle's ability to contract." And my response is, that's absolutely stupid. The lungs are so flabby, the heart is so muscular, how could it possibly be that the lung tissue was pulling on the heart and preventing it from contracting? And I started thinking about it for a while, and I also went to the literature and realized it has absolutely nothing to do with the lungs. You could cut the lungs out. It has to do with the intrathoracic pressure. And so I drew this picture, which, by the way, was in our paper in the New England Journal, and it explains the concept. Let's assume that you have a heart. This is this crescent you see here. and it has a developed pressure of 150 millimeters of mercury, and you measure it in the aorta, that's going to give you a pressure of 150 millimeters of mercury. And if the pressure inside the chest, which I'm going to show as a box here, is 0, the transmural pressure across this box is 150. You have 150 millimeter mercury pressure, you've got 150 millimeter mercury in the aorta. No problem. Now let's give this person phenylephrine, a pure alpha agent, so there's no contractility improvement. And let's increase their arterial resistance such that their mean arterial pressure now goes up to 200. Everything else being the same, well, of course you know that the afterload on the left ventricle is increased to 200. Well, watch. I can keep the mean arterial pressure 150 and just have the person breathe into a minus 50 millimeters of mercury pleural pressure, and you can do that just fine. Occlude your mouth and breathe in. You know how to suck in just fine. You can't create positive pressure very well, but our bodies are designed to breathe in. And you can easily make a minus 50 millimeter mercury. And if you did that, the heart would be in a pressure well, and it would be starting at minus 50 and going up to 200 off that would only be 150. And so you'd still have 150 millimeters of mercury pressure, but your transmural pressure would be 200. So negative swings in intrathoracic pressure should increase left ventricular afterload. So we looked at it in a series of patients, and we were worried about cardiac innervation. So I was at Stanford at the time, so half the patients had this thing done that was really neat. It was called a heart transplant. We were the only transplant center in the world at the time. We had 14 heart transplants and 14 people who didn't. And we didn't have fancy echoes because the person who invented echocardiography was at Stanford at the time, and he was just inventing it, but it wasn't available then. So we used cinefluorography, and we had electrodes that they put around the heart during cardiac surgery so that you could actually watch the volume of the heart. And what we showed was that if you were to look at the strain during inspiration of a Mueller maneuver, the left ventricle and diastolic volumes rapidly rose, but the insystolic volumes rose even further, as if you markedly increased the afterload in the left ventricle. And this is at 3 seconds into the strain. It's immediate, causing the ejection fraction to fall. And positive pressure breathing on the opposite side of Valsalva maneuver markedly decreased the volumes in the ventricle. And if you were to look at the left ventricular pressure to insystolic volume, the insystolic pressure volume relationship in which you plotted the arterial pressure, here as the dots, versus the insystolic volume of these patients, it was a non-physiologic relationship. As you increase the pressure that the left ventricle has to eject against, the volume in the ventricle gets bigger because it can't eject so hard. But if instead of plotting it as the absolute pressure, you plotted it as in the black dots, which was the absolute arterial pressure measured with an arterial catheter, minus the measurement of the pleural pressure, or the transpleural pressure, you can see that it was exactly explaining why the hearts were dilating. Their transmural afterload was increasing. And in fact, it was true for all the patients. So based on that one study, we have since, by Google Scholar as of last month, been cited over 600 times. And it's been listed in F' as one of the important papers that pulmonary and critical care physicians should read. Since that time, we have published a series of papers over the next 10 years exploring the physiologic basis of heart-lung interactions. And from that, we can conclude that spontaneous ventilation is exercise. It requires muscular activity. It consumes oxygen. It requires blood flow to the skeletal muscles of the respiratory system, and it creates CO2. Spontaneous breathing increases the preload by making the pressure in the chest negative, sucking venous return in, but also increasing afterload. And positive pressure breathing decreases preload and decreases afterload. And based on all of these, the following statements can be made. Breathing is exercise. The number of studies that have shown since that time that breathing is exercise is almost too many to count. When we think about weaning from mechanical ventilation, that is the time when patients have cardiovascular collapse. Potentially the reason why we do not understand if a patient can be weaned from mechanical ventilation is because we don't measure cardiac reserve as one of the parameters that we assess in determining if a person can wean. Because if I have to have the exercise to walk up 2 flights of stairs, which is what the equivalent may be to breathe spontaneously if I've got lung disease, and I don't have that ability cardiovascularly, I can't get off the ventilator. And the number of people who have shown that weaning is a cardiac stress test is, again, almost too numerous to count. The first one's more important than the rest only because Jean-Louis Thibault was one of the major authors on that paper, and it was a beautiful study that showed that COPD patients, when put on to spontaneous breathing, would have their wedge pressure go from somewhere around 12 or 15 up to 40. And if you didn't put them back on the ventilator, they would die. And they died of heart failure. If you have, therefore, heart failure and you want to reduce it, what do? Based on these data, we have shown that CPAP, by abolishing the negative swings in intrathoracic pressure, decreases acute cardiogenic pulmonary edema. And in fact, today, the primary treatment for acute cardiogenic pulmonary edema is CPAP. It's the first thing you're supposed to give, and this is why. Hemodynamic ventilation can be thought of as changes in intrathoracic pressure, but it's also changes in lung volume. And lung volume is important because if you were to look at vascular resistance from the residual volume, which is the smallest the heart is, to resting functional residual capacity or total lung capacity, you would see that the resistance is the least at the normal volume, but higher at both the top and the bottoms. The reasons, though, why it's high at the top and the bottom are different. If you only looked at the alveolar vessels, you would see that with hyperinflation, as you increase transpulmonary pressure, alveolar vascular resistance goes up. And that was shown by Roy Brower. Thus, hyperinflation is going to cause patients with COPD to develop acute cor pulmonale, pulmonary hypertension, and I will show you a study by Antoine Villard-Baron where they looked at aortic pulmonary artery input impedance, showing that this is exactly what happens in these patients. However, at low lung volumes, the lungs collapse, and by the process of hypoxic pulmonary vasoconstriction, you get an increase in pulmonary vascular resistance, and Hakim showed that. And thus, PEEP, if you have a person with ARDS with hypoxic vasoconstriction, and you simply give them PEEP, you'll decrease their pulmonary vascular resistance. But if you give them too much, it'll go up. So hyperinflation is common, and hyperinflation can induce acute cor pulmonale by increasing the pulmonary vascular resistance. And in fact, Canada, from the late Dr. Bill Sibbald's lab, showed that if you give enough PEEP to reverse the hypoxic vasoconstriction in an acute lung injury model, pulmonary vascular resistance falls. But in that exact same lung, if you increase PEEP further, pulmonary vascular resistance goes up, just like it does in normal people. This is the studies by Antoine Villard-Baron and François Jardin. François Jardin should get a lot of credit for the work that he was doing, taking to the bedside echocardiography and understanding what happens in critical illness. In this study, and Antoine has focused half his life on acute cor pulmonale, maybe more than half your life, but a lot of it. And what he looked at was the degree to which acute cor pulmonale occurred in patients with ARDS. And you can see that it progressively decreases over time. But more importantly, if you have acute cor pulmonale because you have pulmonary hypertension, those patients are the sickest, and those are the ones that are going to die. One of the things that their group also showed is that the low tidal volume ventilation, the lower levels of PEEP we're giving now, has markedly reduced the amount of cor pulmonale we've seen because it's prevented this hyperinflation. Hyperinflation-induced pulmonary edema. So since the heart is in the chest, we have increases and decreases in thoracic pressure is going to affect the pressure gradients for venous return. Beverly Morgan showed that in 1966. Unfortunately, she's a physiologist, and she was not much of a clinician, so it was simply a description of this fact. We showed the same things later, which was that with spontaneous breathing, venous return increases and right ventricular stroke volume goes up. And with positive pressure, as you raise right atrial pressure, venous return decreases. And based on that, you can see that with a spontaneous breath, you get an increase in right ventricular stroke volume as the pleural pressure falls. But if you have an obstructed breath, because the airway pressure and pleural pressure fall the same, look at how much there's an increase in stroke volume. So this is why patients who have loaded spontaneous inspiration can develop heart failure. Heart failure increases with the depth of ventilation, Loaded spontaneous inspiration causes edema. Inspiratory impedance can be used in CPR to increase venous return because venous return is the primary limit of cardiac output during CPR. And when you have obstructive sleep apnea and it's associated with hypoxemia, that causes heart failure. And the reason you get heart failure is not the hypoxemia, it's the increase in afterload with the obstructive breaths, because if you reverse those, as the final paper shows, the heart failure goes away. And with André Deneau, we then looked at the hearts of human beings and looked at the left ventricular volumes, and you can see with positive pressure breathing, the decrease in venous return shows that. And with Jean-Louis Thibault and Frederick Macquart, we looked at the heart-lung interactions to determine stroke volume and pulse pressure variation, and that is a measure of volume responsiveness. And the higher your pulse pressure variation, the more volume responsive you are. Doesn't mean you need fluids, but it definitely shows that. And the number of papers that have shown that pulse pressure and stroke volume variation, or their surrogates, predict volume responsiveness is ridiculous. More importantly, using this to improve outcome as a treatment to guide therapy, Venous showed in a meta-analysis that using functional hemodynamic monitoring goals based on heart-lung interactions, they can now improve outcome. So in summary, heart-lung interactions are central to explaining the normal and diseased cardiovascular states, and these will be discussed by the other speakers as we go forward for the rest of this session. They're readily manipulated for good and bad by ventilator management. Although my initial focus when I was at Stanford was on the right ventricle, no one who studies heart-lung interactions cannot go into it without a deep respect for right ventricular function. And applying the readouts of these interactions has enabled functional hemodynamic monitoring approaches to diagnosis in patients. I just wanted to give you a list of my co-authors on these studies from the various hospitals I was at, both in the United States and in Europe. Thank you for your attention.